Welcome to the deep dive. So, you sent in your nursing health assessment materials and, well, we've gone through them to really pull out the essentials for you.
Yeah, think of this as a way to get a handle on the core ideas, the practical stuff in health assessment.
Exactly. Our mission here is to clarify how healthcare professionals actually gather and, interpret patient health information, focusing on what's really crucial without getting lost in the weeds.
That's the goal. We want to go beyond just definitions and really explore the why, give you some actionable insights into building that comprehensive understanding of a patient.
Okay, so first up in the materials, the two main types of assessment data. Let's start with subjective data.
Right. This is basically what the patient tells you, their perspective.
It's their story, isn't it?
Yeah.
Not just like name and age, but the important stuff, the history of their current illness, past health, family history.
And lifestyle stuff too, like diet, exercise, substance use. It's all part of their narrative.
Then there's the other side, objective data.
This is what we observe, what we can measure directly.
So physical things we see, skin color, posture, how they're acting.
Appearance, behavior, sure, but also body functions like heart rate, respiratory rate, measurements like blood pressure, temperature.
And lab results too, right? Like blood counts or x-ray findings, things we can actually see or test.
Exactly. Concrete findings.
And putting these two together, the subjective and the objective, that creates the database.
Precisely. It's like assembling clues from different sources to get that full picture of the patient's health.
Which brings us to the next step, which sounds fascinating. Diagnostic reasoning. How do you actually analyze all that data?
Well, it's a process. You start by identifying cues.
Cues, like clues.
Sort of, yeah. The materials define a cue as any piece of information, a sign, a symptom the patient mentions, maybe a lab value.
Okay, give me an example.
Okay. Say someone has a fast heart rate, high blood pressure, and they're breathing quickly. Those are cues.
That might point towards something like anxiety.
Could be, yeah. That's the reasoning part, and there are different ways we reason.
The notes mentioned a few types. Abductive.
Right. Abductive reasoning is like making the most likely guess with the info you have, even if it's incomplete. Like fatigue and paleness might suggest anemia.
Even before the labs come back.
Oh, okay.
Then there's deductive reasoning, applying general rules. If we know disease X causes symptoms A, B, and C, and the patient has A, B, and C.
You deduce they might have disease X. Makes sense. And inductive.
Inductive is seeing patterns. You notice certain signs and symptoms often cluster together with a specific condition, so that pattern guides you.
So it's like being a detective, really. Looking at clues, patterns, applying rules. The notes also bring up the ADPIE framework.
Yes, ADPIE. Assessment, diagnosis, planning, implementation, evaluation.
And it's presented as a cycle, not a straight line.
Definitely a cycle. You assess, diagnose, plan the care, implement it, and then crucially you evaluate how it went.
And that evaluation feeds back into the next assessment.
Exactly. It's ongoing. You're constantly learning and adjusting the plan. It's dynamic.
All this reasoning and data gathering leads to clinical judgment. Right. Which is about using the best evidence, your experience, and your critical thinking skills to make good decisions for patient care.
Now, the materials also talked about different kinds of databases depending on the situation.
Yeah, context matters. First, you've got the complete or total health database.
That sounds like the big one.
It is, usually for a new patient. You gather comprehensive subjective and objective data. It forms the basis for your initial diagnoses.
Okay. Then there's a focused or problem-centered one.
Exactly. You zoom in on a specific issue. Like someone comes in with a cough, you focus on the respiratory system. Doesn't matter if it's short-term or long-term problem.
Got it. And follow-up databases.
Those are for tracking progress. You're checking how things are going with the known problem, seeing if the treatment is working, making adjustments.
And then the emergency database. That sounds intense.
It is. It's about getting critical info super fast in an urgent situation. Allergies, current meds, what happened, anything needed for immediate stabilization.
That prioritization. And it brings us to the ABCs, doesn't it?
Absolutely. Airway, breathing, circulation. Always, always the top priority. First level priorities.
If someone's airway is blocked, nothing else matters right then.
Precisely. Then you have second level priorities.
What falls into that category?
Things that are urgent but not immediately life-threatening, like a sudden change in mental status or maybe early signs of really low blood sugar needs quick action to prevent things getting worse.
And third level.
Important, but can wait until the urgent stuff is stable. Managing a chronic cough that isn't worsening, maybe long-term health teaching.
And underpinning all this decision-making is evidence-based practice, or EBP.
Yes, it's not just this is how we've always done it.
Right. It's about blending the best research evidence with clinical expertise.
And importantly, the patient's own values and preferences. You have to question tradition if the evidence doesn't back it up.
Okay, shifting gears a bit. The materials really emphasize cultural assessment. It's clearly not just about the physical body.
Not at all. Cultural competence is huge for building trust and giving good care. And it starts with cultural awareness.
Meaning, recognizing our own biases.
Exactly. Understanding your own cultural lens before you try to understand someone else's. It's fundamental.
The notes mention some interesting U.S. demographics, too. The idea of an emerging minority majority by 2030.
And that something like 22% of people speak a language other than English at home. It highlights the diversity we encounter.
So what key cultural things should we consider?
Oh, quite a few. Things like their heritage, specific health beliefs or practices, communication styles, family roles in decision-making, nutrition, spirituality, beliefs about death.
Even how they interact with healthcare providers based on past experiences.
Right. And asking open-ended questions about spirituality, for example, can be really insightful.
The concept of cultural humility also came up. What's that about?
It's less about being an expert on every culture, which is impossible, and more about maintaining an attitude of respect and openness.
So valuing other beliefs, recognizing variations within a culture.
Avoiding stereotypes and genuinely valuing differences, it's a commitment to lifelong learning.
And practically speaking, the notes stressed using layman's terms.
Absolutely crucial. Medical jargon can be a huge barrier. We need to speak plain language to make sure patients actually understand.
Which leads us nicely into the interview itself. This is where we gather so much of that subjective data.
It is, and it's way more than just firing questions. It's a real interaction.
What are the main goals of the interview?
Well, several. Understanding their beliefs and concerns about health, identifying strengths and problems, building that rapport and trust.
And even starting some health promotion teaching right then.
Exactly. And remember, the patient is the expert on their own health experience. Our job is to listen.
A successful interview gets complete, accurate data, builds trust.
And sets the stage for good health education. It's foundational.
The idea of an interview contract was mentioned too, setting expectations.
Yeah, it's good practice. Just clarifying the basics up front. Time, place, who's involved, the purpose, how long it might take, confidentiality limits. It sets a clear framework.
And communication techniques, starting with a formal introduction.
Short and formal, yes. Then, in the working phase, you use a mix of questions.
Open-ended, like, tell me more about, to get them talking.
Right. And closed-ended questions for specific facts. Do you have allergies? When did the pain start?
And listening seems key. Patient-led techniques.
Definitely. Things like facilitation little prompts like, or go on, using silence effectively, reflecting back what they said.
Showing empathy, asking for clarification if you're unsure. Makes sense.
And then there are interviewer-led techniques, too.
Like confrontation. That sounds tricky.
It has to be done carefully. Pointing out inconsistencies, maybe. Also offering interpretations. It sounds like you're feeling. Giving explanations and summarizing periodically.
Okay. But there are pitfalls, too. The notes listed 10 traps.
Oh, yes, the traps. Things to avoid,
Yeah.
like false reassurance, don't worry, everything will be fine.
Or giving unwanted advice, using authority to shut them down.
Using avoidance language like passed on instead of died. Using jargon they won't understand.
Leading questions that suggest an answer, talking too much yourself, interrupting.
And asking too many why questions, which can sound judgmental. It's a good list to keep in mind.
And our own internal state matters too, right? Liking people, empathy, listening skills.
Absolutely. Those internal factors shape the whole interaction.
As does the external environment. Privacy is a big one.
Huge. Minimize interruptions. Sit at eye level, equal status seating, professional dress, and try not to bury your head in notes constantly, especially at first. Maintain connection.
There were specific points about interviewing older adults as well.
Yes. Address them respectfully, allow extra time, pace the interview, be mindful of physical limits.
And recognize their response time might be longer. Don't rush them.
And if language is a barrier, a qualified medical interpreter is non-negotiable.
Health literacy also came up, making sure patients truly understand.
Critical. Use simple language, maybe provide written materials at an appropriate reading level, and definitely use the teach-back method.
Teach-back.
Where you ask them to explain it back to you in their own words. It confirms understanding way better than just asking, do you understand?
Good tip. And for communication between professionals,
Mhm.
SBAR.
SBR, situation, background, assessment, recommendation. It's a structured way to give updates clearly and efficiently. Very useful in busy settings. The example in the notes showed that well.
And finally, the physical environment for the interview needs to be right, comfortable, temp, good lighting, quiet.
Remove distractions. It shows respect and helps them feel comfortable opening up.
Okay, let's transition to the complete health history. This is where we really start putting all that subjective and objective data together.
Right. It's the foundation, along with the physical exam and labs, for making diagnoses.
What are the key parts? Starts with biographical data, Algie.
Name, age, contact info, etc. Then you document the source of the history.
Meaning who gave the information and if they seem reliable.
Exactly. And note any special circumstances, like using an interpreter. Then comes the reason for seeking care, the chief complaint.
In their own words, ideally.
Yes, if possible. And it's good to distinguish signs, what we observe from symptoms, what they feel.
Then the HPI history of present illness. This is the deep dive into the main problem.
Correct. Location, quality, severity, timing, setting, what makes it better or worse, associated factors, and the patient's perception of it all. The classic PQRSTU or old Descartes mnemonics cover this.
Got it. Then past medical history.
Childhood illnesses, accidents, surgeries, chronic illnesses, hospitalizations, allergies, current medications, prescription, over-the-counter, herbs, everything.
Family history is important too. Looking across generations.
At least 3 generations of blood relatives, major medical conditions, age of onset, cause of death, ethnicity, and consanguinity if relevant.
Then the review of systems. Going head to toe.
Pretty much. A systematic check for symptoms related to each body system, general health, skin, head, eyes, ears, nose, throat, respiratory, cardiac, GI, GU, musculoskeletal, neuro, etc. It catches things they might not have mentioned.
And finally, the functional assessment. How they live day to day.
Right. Activities of daily living, ADLs, self-esteem, activity, exercise, sleep, nutrition, coping strategies, personal habits like smoking or alcohol.
IPV screening, occupational health, drug use. The CAGE questions for alcohol substance use were mentioned here too.
Yes, a quick screen for potential issues.
Okay, moving on to mental status assessment. This is about emotional and cognitive function.
Exactly. How they're functioning psychologically, coping with stress. It's about finding that balance for social and work life.
And the framework is ABCT.
Appearance, behavior, cognition, thought process. A good way to organize observations.
So for appearance, we're looking at posture, movements, dress, hygiene.
Yep. Erect posture, coordinated voluntary movement, appropriate dress, clean and groomed, that's typical. Abnormal could be tense posture, detects inappropriate clothing, poor hygiene.
Behavior level of consciousness, facial expression, speech.
Right. Awake, alert-oriented. Facial expressions match the mood. Speech is clear and coherent. Abnormalities might be lethargy, agitation, flat affect, pressured speech, slurring.
Cognition involves orientation, attention, memory.
Person, place, time awareness. Can they focus? What's their recent and remote memory like? Disorientation or significant memory loss would be concerns.
And thought process, logical thinking, content.
Yeah, are their thoughts logical, coherent, relevant? Any evidence of delusions, hallucinations, obsessions? How's their insight and judgment? Illogical thinking or perceptual disturbances are red flags.
When would you do a full mental status exam beyond just observing during the history?
If you notice concerning behavior or affect changes, if family members raise concerns, if there are signs of organic issues like confusion or poor judgment, known brain lesions, aphasia, or a sudden onset of psychiatric symptoms.
Makes sense. Now let's touch on substance use assessment. The notes define different levels of alcohol use.
Light, moderate, heavy, binge drinking, yes, specific definitions based on quantity and frequency.
And specific risks for older adults were highlighted.
Definitely. Their bodies process alcohol differently, increased bioavailability, higher concentration due to less muscle mass.
Plus, more potential drug interactions from polypharmacy. Increased risk for falls, cognitive decline.
Depression, GI issues. It's a vulnerable group.
And we look for clinical signs of substance use disorders.
Intoxication, abuse patterns, dependence, tolerance needing more for the same effect, and withdrawal symptoms when stopping.
Nicotine was mentioned too, signs of intoxication and withdrawal.
Yes, appearance changes, behavioral shifts with intoxication, and then the physical and psychological discomfort of withdrawal.
The materials contrasted CAGE and CIWA. What's the difference there?
CAGE is a quick screening tool. Cut down, annoyed, guilty, eye-opener, primarily for lifetime alcohol abuse dependence risk. Its limitation is it doesn't tell you about current drinking or withdrawal severity.
There is CIW.
CIWA, Clinical Institute Withdrawal Assessment for Alcohol, is used to objectively measure and monitor the severity of active alcohol withdrawal. It scores things like nausea, tremor, sweats, anxiety, agitation, sensory disturbances. 10 criteria in total, used to guide treatment during withdrawal.
Got it. Okay, shifting to another sensitive area. Domestic and family violence assessment. IPV categories were listed.
Right. Physical, sexual stalking, and psychological aggression are the 4 main types of intimate partner violence.
And screening requires real sensitivity.
Absolutely. Ask open-ended questions, ensure privacy, interview them alone if possible, listen for cues or inconsistencies, know your reporting loss.
And standardized tools can help, like HICS or WAST.
Yes, those tools can provide a structured way to ask.
Documenting suspected child abuse sounds incredibly important and complex.
It is. Use the child's own words whenever possible. Be aware the abuser might be present. Interview separately if they're verbal. Document caregiver statements if not.
And always follow your institution's specific protocols, which might involve trained forensic interviewers.
Crucial. And the basic types are neglect, physical, sexual, and emotional abuse.
Okay, let's move to the hands-on stuff. Assessment techniques. We use our senses, right?
Sight, smell, touch, hearing, absolutely.
And the 4 core techniques are IPPA.
Inspection, palpation, percussion, auscultation, usually in that order.
Inspection first, just careful looking.
Always first. Good lighting, proper exposure, maybe using instruments like an otoscope or pen light. Look before you touch.
Palpation is using touch. What are we feeling for?
Texture, temperature, moisture, organ location size, swelling, masses, tenderness. Start light, then go deeper. Use different parts of your hand for different things, fingertips for fine details, back of hand for temperature.
Percussion, the tapping part. What does that tell us?
Organ size and location, density, air, fluid, solid. Detecting superficial masses, sometimes eliciting pain or deep tendon reflexes. The vibration goes down about 5 centimeters.
And auscultation is listening, usually with a stethoscope.
Right, listening to heart, lung, bowel, and sometimes blood vessel sounds. The stethoscope helps block out other noise.
But there's an exception to the IPPA order.
Yes. For the abdomen, it's inspection, then auscultation, then percussion, and palpation.
I listen before touching the belly.
Because palpating or percussing can stir up bowel activity and change the sounds you'd otherwise hear naturally. So look, listen, then feel and tap.
Good point. What about adapting these for older adults?
Positioning is key. Keep them comfortable, minimize changes, maybe use supports, pace yourself, allow rest periods, maybe break the exam into parts.
And physical touch can be important.
Very much so, especially if other senses are diminished. But also, be careful not to mistake sensory loss, like poor hearing, for confusion. Sudden confusion often means illness.
Let's talk about the general survey. That's the first impression.
Yeah, your overall study of the whole person. General health state, obvious physical characteristics, objective measures, your immediate sense of them.
What are the main components?
Physical appearance, body structure, mobility, and behavior. It's a snapshot.
Are there typical findings in older adults for the general survey?
Some common age-related changes, yes. Maybe changes in body shape from fat redistribution, a more flexed posture, perhaps a wider gait with shorter steps.
Weight might decrease slightly, height too, due to trunk shortening.
Exactly. And when recording weight, use a standard scale, same time clothing for serial weights, recording kilogram pounds compared to ranges and previous weights.
And for kids, the general survey needs context.
Totally. Interpret findings based on their age and development. Observe behavior, parent bonding, measure weight, length, head-chest circumference, and use those CDC growth charts.
Okay, nutrition assessment. Crucial across the lifespan. Infants and kids first.
Rapid growth phase, especially the first year, weight doubles, triples, length increases. Huge brain development, too.
Benefits of breastfeeding were mentioned.
Aminoglobulins, IgA, ideal fat calories for the nervous system.
Yeah.
And kids need snacks because they're so active. Adolescence is another growth spurt time.
What subjective data do we gather for nutrition?
Meds and supplements are key. They can affect nutrients, and culture plays a huge role, right? Occupation, income, religion, gender. Table 12.1 had good examples.
What are the different ways to assess nutrition?
There's the 24-hour recall, food frequency questionnaires, food diaries where they track intake, direct observation sometimes, especially with feeding. And then a comprehensive assessment pulls together dietary history, clinical info, physical exam findings, measurements, labs,
A dietary intake screening might involve.
relevant history, maybe a focused diet history, checking skin muscles neuro for deficiency signs, basic measurements like height, weight, checking labs, and providing education.
And older adults have specific nutritional risks.
They do. Higher risk for both under and overnutrition. Reasons can be financial, mobility issues, slower metabolism, relying on cheaper processed foods.
Plus physiological changes like poor teeth, decreased taste smell, slower GI tract, less absorption, lower energy needs.
And that loss of muscle mass, sarcopenia, sometimes combined with obesity, sarcopenic obesity, lots of factors.
Okay, let's move to the head, face, neck, and lymphatics. Basic anatomy review.
Cranium bones, frontal, parietal, occipital, temporal. Facial bones, nasal, zygomatic maxilla, mandible with the TMJ. Sutures connect them. Fontanelles in babies allow growth.
Facial exam is mostly observation, symmetry, expression.
Yeah. And asking about common things like headaches, we also palpate the lymph nodes in the head and neck region.
Infant assessment has some unique points. Head size,
Measure circumference up to age 2, then yearly to 6. Heads bigger than the chest at birth. Watch for variations like caput succedaneum.
which crosses suture lines and goes away on its own.
Right. Versus cephalohematoma, which is under one bone, doesn't cross sutures, gets reabsorbed. Also molding from birth and positional flattening.
And fontanelles, soft spots.
Anterior diamond closes 18 Carmel. Posterior triangle closes 2-3 Almo. Feel gently bulging or sunken indicates problems.
Tonic neck reflex is normal for a bit.
Disappears around 3-4 months. Percussing the skull might give a cracked pot sound before closure. Auscultation over the temples might reveal bruits common under 5 or with anemia.
So the checklist is inspect palpate skull, face, neck, check ROM, feel lymph nodes, trachea, listen to thyroid if enlarged.
Pretty much covers it.
Now, nose, mouth, and throat. Nose exam.
Look externally, symmetry, lesions. Check patency, breathe through each nostril. Then internally, with a speculum, look at mucosa, septum, turbinates.
Sinus assessment involves pressing.
Yep. Thumbs press up under eyebrows for frontal sinuses, below cheekbones for maxillary. Should feel pressure, not pain.
But only maxillary in young kids.
Right. Frontal aren't developed until 7 or 8. Pain, swelling, asymmetry are abnormal. Bending over pain can also suggest sinusitis.
Transillumination, shining a light.
Less common now, but yeah. Dark room, otoscope light against the sinus. Red glow is normal. Dull means fluid inflammation.
Tongue observation, tonsil check.
Look at tongue color, texture. Check tonsils for size, color, symmetry, exudates, swelling.
So the checklist. Inspect outside, inside nose. Check patency. Palpate sinuses. Then inspect the lips, teeth, gums, tongue, mouth lining, palate, uvula, tonsils, back of throat. Palpate mouth if needed.
That's the routine.
Finally, let's wrap up with the functional assessment of the older adult. Aging population is growing fast.
Huge growth projected. And they're diverse, young, old, middle old, old.
A comprehensive geriatric assessment is key. It's multidimensional.
Physical, mental, functional, economic, pain. The goal is finding strengths and limits to prevent decline, catch things early.
What are ADL's drives? Advanced activities.
Beyond basic self-care, activities in family, society work, hobbies, volunteering, socializing, things that give life meaning.
How do you test those? 2K test.
Timed up and come up. Beal rise from chair, walk 10 feet, turn, sit. Over 12 seconds suggests high fall risk. There are others like PPT, POD-L2.
Cognitive assessment is also part of it.
Attention, memory, orientation, language, visuospatial skills, executive function, planning, decisions. Changes can be due to dementia, delirium, depression.
Screening tools like MMSE or MoCA have.
They screen, yes. MMSE 24, MoCA 26 suggest impairment, but they aren't diagnostic tests on their own.
Social domain matters too. Support systems.
Relationships, community involvement, formal, informal help, all important.
And the setting impacts assessment. Acute care versus home care.
Definitely. Acute care can sometimes worsen decline. The goal across settings is maintaining independence exercise, health maintenance.
Environmental assessment, home safety is part of this too.
Crucial for preventing falls. And assessing pain is vital. It impacts everything.
Can we quickly clarify ADLs versus IADLs again?
Sure. ADLs are the basics. Bathing, dressing, eating, toileting, moving around like getting out of bed. Essential self-care.
And IADLs.
Instrumental activities of daily living. More complex tasks for independent community living. Managing money, shopping, cooking, taking meds, using the phone, transportation.
So assessing both gives a fuller picture of independence.
Exactly. You need both to understand their overall functional status.
Wow. We have really covered a massive amount of crucial information in this deep dive on health assessment.
We certainly have. Just to quickly touch on the big themes again. We hit the types of data: subjective, objective,
The whole diagnostic reasoning process, why cultural sensitivity is so incredibly important,
those effective interviewing techniques, avoiding the traps.
the pieces of a complete health history, the mental status check using ABCT,
Understanding substance use, recognizing IPV signs, the hands-on assessment techniques like IPPA.
the general survey nutrition needs at different life stages, and all those details about functional assessment in older adults.
And you can really see how interconnected it all is, can't you? You can't really isolate one part. Holistic care means looking at everything.
Absolutely. So as we wrap up, here's something for you, our listener, to think about.
Hmm.
Considering this huge range of factors that influence someone's health, is there one specific area we talked about today that you think it's maybe overlooked or shortchanged most often in our really fast-paced healthcare world?
That's a good question.
And what might be the downstream effects, the consequences if that area is consistently missed? Something to mull over. Thanks so much for joining us for this deep dive.